Good morning, everybody, and many thanks for the kind invitation to speak at your event for the British Heart Valve Society this morning. I've been asked to speak and share my thoughts on surgery or conservative management for prosthetic valve endocarditis. My name is Prof F Bhatti. I'm a consultant cardiac surgeon at Morrison Hospital in Swansea, and I have no conflicts of interest to declare. So let's start with definitions. Prosthetic valve endocarditis tends to be grouped as early or late. Although somewhat artificial, early is said to be before the onset of a year, and is often attributed to seeding of microorganisms at time of surgery or otherwise hematogenous spread. In addition, it might be due to inadequate antimicrobial therapy for the original bout of endocarditis. Late is identified as greater than 1 year and often is due to other concomitant infections that then seed onto the valve. So how common is it? It's said that 1 to 6% of patients with prosthetic valves are at risk of endocarditis. The absolute risk appears to be 1% risk per patient year. About a third of all cases of endocarditis are related to prosthetic valve endocarditis, and the incidence is on the rise. So first of all, to treat it, you need to make a diagnosis. And I think the most important thing is to have a high index of suspicion. We all know about the modified Dukes criteria and the ESC guidance around these. The mainstay of the diagnosis, of course, positive blood cultures, echo findings suggestive of endocarditis, and TOE is key here, as well as a clinical picture in terms of symptoms and signs of the patient. A reminder for the younger colleagues about modified Duke criteria, major and minor, and also the ESC definitions. And it's essentially, you can see you either find microorganisms on successive blood cultures. The imaging by TOE can often show vegetations or valve destruction or paravalvular leaks, or if it's very aggressive, abscess or fistula formation. And of course, you have the clinical signs, as I've already mentioned. And one thing I can't emphasize enough, which is all across the 2015 guidelines on management of endocarditis, is that TOE is key, whether you're making a diagnosis, whether you're monitoring the effectiveness of your treatment or perioperatively or postoperatively, and all roads really lead to TOE. So what is the treatment? Well, the first thing to say, and again, emphasizing the guidelines, is the importance of an endocarditis team once you've made a diagnosis. Other than just very straightforward prosthetic valve endocarditis with no signs of valve deterioration that can be managed locally, really these patients ought to be managed in secondary or tertiary care settings where there's an endocarditis team, often consisting of microbiology input, cardiologists, often with special expertise in TOE, as well as a surgeon. And that's by no means exhaustive, a list of people who are involved. Clearly, you need to guide your antimicrobial therapy to the organisms found. And one of the principles is that often you have longer antibiotic therapy than in native valve endocarditis. You need to treat any heart failure that the patient is suffering from. And along with all the treatments, active treatments, you really need to do active monitoring to see how both the disease is responding to your treatment and your antibiotic therapy, and also to look out for complications. And this includes serial TOEs, serial ECGs, for example, looking for prolonged PR interval. That might be a sign of destruction near the AV node, for example, a root abscess, CT scanning, and in particularly in prosthetic valve endocarditis, PET can be useful to identify infection around the annulus of the sewing ring. So what are the indications for surgery then? Three main areas really: hemodynamic compromise, uncontrolled sepsis, or embolic phenomena, or prevention thereof. In terms of hemodynamics, once the heart failure is treated, if you cannot control it, or if there's sudden severe regurgitation, whether that be a prolapse or destruction or perforation of a leaflet in a bioprosthesis, or a dehisced ring in terms of mechanical prosthesis. If it's very severe, perhaps even rocking of the whole valve. And sometimes obstruction, perhaps of a bileaflet tilting disc, if a vegetation or thrombus with infection on it actually obstructs one of the leaflets in a half open, half closed position, there's not only obstruction, but also catastrophic regurgitation. Often that can necessitate emergency surgery. In terms of sepsis, it might be uncontrolled systemically, but also local signs of aggressive destruction of tissue. You can see how going in early in uncontrolled sepsis may actually lead to the new prosthesis being affected, thus making timing really a challenging issue. And of course, embolic phenomena, either somewhat controversially, but going on the size of vegetations and the mobility of the vegetation in terms of presumed risk of developing an embolus, or perhaps after the event when perhaps a cerebral thromboembolic event has happened. And then again, timing is difficult. You need to be absolutely sure that no bleed, concomitant bleed has happened. So difficulty in indications are clear, but the timing is not clear. There are certain groups of organisms, for example, staph, that you would tend to go in earlier rather than later because its aggressive nature. And these are summarized in table 22 of the ECS guidelines on indications for surgery. Now, interestingly, you'll look at the chart and it says indications and timing of surgery. But the timing, other than emergent surgery, is all urgent. It doesn't really tell you exactly when, and that's where your clinical judgment and the endocarditis team come into play. And you'll also note that both the indications are pretty similar for both native valve endocarditis and prosthetic valve endocarditis. I just wanted to highlight that. So what about timing? I've talked about the pros and cons of going in early versus going in late. And this study in Jack from 2020 actually looked at this very issue. And the findings were essentially that after about a week or two of antibiotics, the probability of sterilizing the field with further antibiotic therapy is not that, the benefit is not clear. So the benefit happens early. So really delaying surgery between after 1 to 2 weeks may not be of benefit. And clearly you have the risk of the infection becoming more aggressive or the patient deteriorating in their general self. So maybe there will be a shift towards earlier surgery. So if you are going to theatre, what are the principles of surgery? Well, clearly it's really important to debride all the infected material, remove all the prosthesis, sutures and all, and repair any defects that may have occurred due to destruction around the site of the annulus or any abscess formation. And then you can choose depending on the patient's age and comorbidities, you can choose what kind of prosthesis you put. Most people will choose a mechanical bioprosthesis or bioprosthesis, but there is some merit in using homografts, but this usually tends to happen in more specialist centres. And also in terms of surgery, this isn't straightforward surgery where people are first time valve replacement. It's technically challenging, not just because of a redo, but the amount of destruction of tissue you find, and then the amount of repair you may need to do to actually almost form a neo-annulus sometimes to implant a new valve into. The patients are really often very sick and their perioperatively can be quite unstable, not just hemodynamically, but in terms of a systemic inflammatory response that occurs in response to being placed on cardiopulmonary bypass. They often end up on significant amounts of inotropes. You can see people becoming vasoplegic and requiring high doses of constrictors with all their attending side effects, and often they need renal support and a prolonged ITU stay. And of course, relapse or reinfection, depending on the definitions you want to use, is always a risk. So this is not straightforward surgery. This is high-risk surgery done in high-risk patients that need it. I think the key really is that whether you're having medical or surgical treatment of your prosthetic valve endocarditis, you need a multidisciplinary approach. And the endocarditis team, as emphasized in the 2015 guidelines, is key, whether to look at the timing of surgery, the indications of surgery, managing the organism, seeing how effective the antibiotics are being, and of course, all putting this into the context of the condition of the patient. Now, I can't do a talk on prosthetic valve endocarditis without mentioning antibiotic prophylaxis in dental procedures. As we all know, in NICE guidelines in 2008, recommended that antibiotics were not given for routine dental work. There was some concern both amongst cardiologists and surgeons about what this might lead to. And Dyer and colleagues published a paper in The Lancet in 2015 looking at an increased incidence of endocarditis from 2008 to 2013. Of course, it's difficult to attribute cause and effect, but there was certainly an increase, a significant increase in the diagnosis of endocarditis. This and other papers led to the NICE guidelines being reviewed in 2015 and updated in 2016. And one word, essentially the main thrust was that one word was added, which was that antibiotics were not to be given routinely. And this gave clinicians, dental surgeons and people giving advice, the caveat to be able to prescribe antibiotics if they felt it was clinically relevant. The Scottish guidance went somewhat further and actually has in a flowchart that input should be given, sought from cardiologists and decisions made on clinical grounds jointly by the dentist and the patient. And this same authors published again in 2020 in The Lancet, looking in paper entitled An Alarming Rise in Incidence of Infective Endocarditis in England since 2009. Why? And again, you can see from this key figure from the paper that the incidence continues to increase. So this is really something that we all need to be mindful of and continue to keep on our radar. So what are my take-home messages about prosthetic valve endocarditis and its treatment? I think the main thing is that to treat it effectively, whether medically or surgically, you need to make the diagnosis. And this can be a challenge. Often it presents as a non-specific illness, maybe a malaise, quite slow and indolent. So you need a high index of suspicion. And I think key here is education, both of patients who have a prosthetic valve to be vigilant and look out for potential symptoms and signs without frightening them, of course, and for healthcare staff, both primary and secondary, both in primary and secondary settings, to look out for and be thinking of endocarditis in these patients. We all know about the highly effective campaign called Think Aorta to highlight the importance of considering a diagnosis of aortic dissection. Maybe it's time for this society to start a campaign called Think Endocarditis. And so I'll leave that thought hanging there. And finally, whatever the treatment, whatever the controversies, the timing of surgery, duration of antibiotics, the identifying the correct organism, the key is that these are complex decisions in complex, very sick patients with high chances of both mortality and morbidity. And it's vital that the endocarditis team work together to try and do the best for these very sick patients. So those are my thoughts on prosthetic valve endocarditis. I'm very grateful to the organiser, in particular Dr. Dobson and Dr. Shah, for the kind invitation to speak. I hope you enjoy the rest of your meetings. Many thanks and goodbye.